Good evening, everyone who's in the same time zone as I am. And I think Dr. Colin West, good afternoon from your time zone in the USA. Thank you for joining us on our webinar entitled Solutions and Strategies for Building a Resilient Healthcare Workforce in Namibia. My name is Tomika Zeru, and I'm going to be your host for today's seminar, representing Visionary Healthcare Consultancy Services. I hope that you will be motivated towards improving the burnout in healthcare after this webinar. This webinar is part 2 of our series on healthcare burnout in the healthcare workforce. The first webinar was about a month ago, again with Dr. Colin West, and we talked about the causes, the consequences, and the definition of burnout. Today, we're going to be dealing with the strategies and the solutions and the ways towards building resilience in healthcare. The title of today's webinar is Solutions and Strategies Building a Resilient Healthcare Workforce in Namibia. I'm very happy to say that people from different countries in Africa have registered. We've got registrants from Ethiopia, we've got Malawi, we've got Botswana, South Africa, and yes, Namibia. So everyone is welcome, and I'm glad that that name Namibia didn't deter you from registering, because this is all about helping out in resource-limited settings. So before I introduce Dr. Colin West, just a few pointers. The chat is available for any information that you would like to send us, for any communication. We've got a Q&A tab that you can drop questions into as the speaker is presenting. We've also got the option of live questions at the end, if you would like, so that you can raise your hand and then we can unmute you, time permitting. Please make sure that your mics are muted throughout the session. And if you have any questions, we'll deal with it at the end. So I am honored to present to you and to introduce you to our distinguished speaker, Dr. Colin West. He's originally from Seattle, and he received his MD and Ph.D. in Biostatistics from the University of Iowa in 1999. He completed residency and chief residency in internal medicine at the Mayo Clinic and joined the faculty in general internal medicine in 2004. He is currently professor of medicine, medical education, and biostatistics at the Mayo Clinic in Rochester, Minnesota, USA. He's the director of the Mayo Clinic Program on Physician Wellbeing and was named the first medical director of wellbeing for the Mayo Clinic in 2022. Dr. West's research has focused on medical education and physician well-being and has been widely published in prominent and peer-reviewed journals, including the Lancet, the Journal of the American Medical Association, and the Annals of Internal Medicine. Dr. Colin West, it is a pleasure to have you with us. And in the name of everyone that is here, I would like to warmly welcome you. You can start.
Wonderful. Thank you, Dr. Zaru. I really appreciate the opportunity to be with all of you again. And for those who maybe can view this on the recording afterwards at times that may work with your work-life integration a bit better as well.
Okay.
So trying to have this be available more broadly. For those who were part of the part 1 session, welcome back. For anyone who's new, hello, it's an honor to be with you. I'm going to bring up my screen here and hope that this works properly. So Tomika, can you tell me, do you have my slide showing?
Yes, I have.
Excellent. So the title as Tamika mentioned, is Solutions and Strategies, Building a Resilient Healthcare Workforce in Namibia. This is part 2 of the 2-part series. I'm going to share my contact information like I did a month ago. Again, a PDF of these slides will be sent to Dr. Zaru. It will be made available as she wishes. You can also reach out to me by email, and feel free to take a look at some of the social media sites that are linked in the slides, where I post every Wednesday a weekly thread on well-being related topics. Last time, we focused on the first 2 bullet points of our overall learning objectives. We talked about the scope of the issue of distress in medicine. We talked about the consequences and the contributors. And the purpose of that was to set a foundation that we could build on to then understand what evidence-based or evidence-informed approaches to promoting well-being might look like. So I'm going to start by just recapping a few of the highlights from that foundation from last session, and then we'll turn to part 2. So as a reminder, my definition of well-being is very broad. It's the state in which an individual can achieve their greatest desired potential as a complete human being. That is what we are aspiring to in our roles, not just in our work in medicine, but more generally as human beings. We know that we don't always connect with this in medicine, whether we're in a lesser or greater resourced setting. We know that there are aspects of our profession that are incredibly challenging for us and can push us toward distress and interfere with our goal of thriving and flourishing. Why does that matter? Well, there's certainly the intrinsic moral argument that we all have a right as human beings to feel some sense of fulfillment in the work that we do. There are other consequences as well, however. So, summarizing a wealth of literature in one slide, there are consequences to patient care. There are consequences to access to care. There are personal consequences relating to medical knowledge acquisition and mental health. And all of this is incredibly expensive to healthcare systems. So perhaps even more relevant to resource-constrained settings, when we often hear that we would love to address well-being if only we could afford to, we need to recognize that we are already paying for suboptimal well-being in healthcare. And so to manage that drain on our systems requires that we have the foresight to make this a foundational priority, so that we can retain and recruit committed, dedicated healthcare professionals where they are needed. We talked about models for drivers of distress. Christina Maslach and Michael Leiter have studied burnout for 4 decades. There are 6 areas of work life, as they call them, that are common across professions and can drive either distress or well-being. These include workload, a sense of control in the work that we do, feeling reward, both intrinsic and extrinsic, sense of community, being treated fairly and with respect, and having our individual values reflected in the environments within which we learn and work. These drivers have been adapted for a medical environment. This is work that comes out of Mayo from about 8 years ago. And what we see here is that efficiency and resources in meeting our patients' needs is relevant. Our workload and our job demands is part of the picture. Having a sense of control, recognizing that we have more to our lives than just our work, and we need to honor and integrate our work and non-work responsibilities. A sense of support socially and connection with other people is something that in medicine we sometimes ignore. Organizational culture and values, and at the center of all of this is meaning in work. And I introduced last time what I call the MVPs of well-being, which is a play on the phrase MVP, meaning most valuable player. But in this case, the most valuable players for well-being are meaning, values, and purpose. Every effective solution to promote well-being for healthcare professionals works in some way by connecting us with meaning, values, and purpose in our work. There are many solutions that are out there, both nationally and internationally, across various organizations. I'm not going to click on any of these links, but they are here as a resource so that if you're interested in thinking about how minds beyond mine have thought about these issues and explored solutions in their local practice settings, they are collected across these repositories, these resource bases. And these are great references for getting additional ideas on what you might be able to do in your local practice environments, no matter what kind of practice environment you happen to find yourself in. So that's all background. That's where we were in part one, sort of hitting some of the highlights. And so what I'd like to do now is turn to a framework for thinking about how to use what we learned in part one to think about how we move forward with solutions. And I want to preface this by emphasizing I cannot give you a prescription to cure burnout or ensure well-being, because this is experienced locally. What I can do is give you an understanding and a framework that you can then map to what your local environment and individual needs are, so that you can, with more confidence, be able to think through what kinds of interventions are more likely to meet my needs and which ones maybe are less likely to be as effective in my local environment. We are all part of a global learning community when it comes to well-being in medicine. What works in Namibia is different than what may work in Malawi. What works within an individual practice in Namibia may differ from another practice in Namibia. And all of that may differ from what works in North America or Europe or Asia, because our health systems are different, our societal norms are different, our procedures and policies are different. What isn't different is the underlying framework for how to think about the drivers of well-being, and then we can adapt those to local environments. So that's what we'll do here in the next 25 minutes, 30 minutes or so, before opening it up to reflections and comments that anyone may have. So the first way to break down strategies to approach well-being is to look at these as either individual or system in nature. We spoke in part one about how the majority of well-being in medicine actually resides within our systems and structures. But we still do have an individual responsibility to bring our best selves to our work. This is also essential because it sometimes feels too big to change our healthcare structures as individuals. So we need to be able to exert control within the locus of control that we have. So trying to change things that are within our individual sphere of influence, because those we do have control over. So while we try to move the big boulders, the big problems in our healthcare systems, we can still be maintaining some control, some agency, some autonomy in how we live our lives individually. So what do those individual strategies look like? Well, first, thinking about identifying our values. It's very common in medical professions as we get incredibly busy that we actually lose sight of why we got into healthcare in the first place. So we need to think intentionally what matters to us most. Why do we do what we do? And for most of us, at the center of that is we want to help other people. And sometimes when we're feeling discouraged or frustrated, it can be grounding and affirming to recognize at the end of a busy day, just take 5 minutes and think about what good did you do today? Did you honor that value that got you into healthcare of wanting to help other people? And think about a few examples, even if they're small things, where you helped other people move forward in their health. We don't do that very often in medicine. At least most of us don't. And unfortunately, what that leads to is that we overrepresent negative influences and experiences and underrepresent all of the amazing things that are happening around us. We work with incredible people. We engage with really interesting and remarkable patients and families, but we don't necessarily step back and reflect on that. And I want to be clear, I am not suggesting that by doing this, we should be ignoring the larger issues that we face. What I'm suggesting is a both and approach where we need to both try to work on the larger issues and make sure that we're not allowing those to drown the wonderful experiences that we all do have on a regular basis in medicine. So identifying those core values and being mindful about what's important to us and trying to live in accordance with that is important. Seeking meaning in our work is also important. What are the aspects of our practices that we enjoy the most? And what ways can we try and bend our practices to do more of those things and be intentional about it? Personal wellness activities are also essential. So self-care, we know, is critical to well-being. That seems fairly obvious. And yet we also know that healthcare professionals often don't sleep enough, don't exercise enough, despite potentially seeming like we should have access to regular medical care. Oftentimes we put ourselves second. And we need to embrace a philosophy that self-care is not selfish. Self-care is actually how we bring our best selves to help our patients and help our healthcare systems. I mentioned a month ago, when you're on an airplane traveling, part of the safety message is, if you need it, hopefully no one ever does, but if you need it, an oxygen mask will drop down from the ceiling. Please secure your own oxygen mask before assisting others. No one has ever, to my knowledge, complained that that's selfish. How dare we secure our own oxygen mask before helping others? And yet in medicine, we put ourselves second because we worry that it seems selfish to take care of ourselves. That's backwards. We take care of our patients. We honor our commitment to our patients by taking care of ourselves first, so that we can be fully present as our best selves when our patients need us. Relationships, religious and spiritual practices, personal interests and hobbies, all of these are part of the personal wellness activity menu. This also requires that we be able to assess how we're doing from a distress standpoint. And although healthcare professionals have a reputation across the world for being somewhat negative and complaining about the systems we work in, it turns out that despite that reputation, when you ask us individually, well, how are you doing? How is your well-being? We still think that we're doing better than our peers. So my colleague Lottie Derby has studied this, and 90% of US physicians rated their well-being as better than the well-being of their peers and colleagues. 90% thought they were above average. Even though we complain about stress and distress, 90% of us thought we were above average. Mathematically, that just doesn't work. What that means is that many of us are underestimating and therefore not taking appropriate action steps to deal with the stress that we are dealing with. So this is an example. I will confess I am not 100% sure that this website will work for you if you're interested in checking it out. It is supposed to offer, through a login screen, an anonymous, free, individual self-assessment that can be repeated periodically with an automatic cadence where emails get sent to you automatically. You choose the email, you choose your password. No one ever sees your data but you. That's the intention. I'm not sure if it's still working completely well, but if it is, this is an example of what this dashboard can feed back. It asks 6 or 9 questions, very simple, very quick. And there are normative populations. Most of these are based in the United States, but the company that runs this increasingly is adding normative populations from other job roles and other geographic locations around the world. That is their intention. You answer a few questions, and it then takes your answers and maps them to norms from the normative population that you select. And people can look at this and say, well, if this is a hypothetical dashboard, in the lower left corner, my work-life integration score is actually poor relative to my peer group. Maybe I want to put a little more attention into that. Maybe I've let that slip a little bit. Or in the upper right, my fatigue is about average for my peer group. But I know that when I am fatigued, I don't function very well. So even though I'm average, that needs to be a priority area for me. So this can help people individualize where they're going to focus some of their well-being needs. Now, I'm not going to say a whole lot more about individual strategies for well-being, and that is intentional. So at least in the United States, and I think this is true around the world, we've heard a lot about what we need to do as individuals to deal with well-being. And unfortunately, this risks sending a message that we are not holding our systems accountable. And it blames us as the victims, if you will, of the environments we're in. We just need to be tougher. What did we expect? That is not a solution strategy. That is actually shifting responsibility. And physicians and other healthcare workers are already plenty gritty and highly resilient. So telling them that they need to be even more superhuman is actually disrespectful. We have data to back this up. So this is a national study of physicians in the United States, and we compared them with a normative sample of employed US population workers outside of medicine. And what we saw here was that the resilience scores for physicians, despite having higher burnout levels than the general public, were still higher. The resilience scores were still higher as well. So despite having more burnout, physicians still had higher resilience. This is true for other healthcare professionals as well. And for anyone who's listening to this or watching this recording, we kind of know this. We know how tough we are in medicine. We know how resilient we are. We adapt to change all the time, even within our stressful environments. Now, resilience is important. Looking at the rightmost panel of this slide, we see that resilience scores, as they go up, we see burnout levels go down. So resilience is a good thing. We should maintain and strengthen it where we can. But even US physicians with the highest possible resilience scores, 30% of them still had meaningful levels of burnout. So resilience, excuse me, is not everything. It's important, it's relevant, it's an individual characteristic that we should strengthen and sustain. But it's not a solution to solve burnout or ensure that everyone's thriving and flourishing in their work. So this slide restates what I just said. I'm going to emphasize the third bullet point. Organizational and structural or system approaches to improve the working and learning environment are mandatory. But again, we need to also be able to optimize what is within our individual sphere of influence. And that's why the individual strategies matter. I'm going to put a bow on the individual strategies for the moment because we're going to shift gears to talk a little bit more about what can we do beyond the level of the individual. So what can organizations, practices, health systems do? Well, there are a number of approaches here, starting very broadly. Number one, values matter. So seeing the values of the medical profession as a whole promoted by your health systems, by your health ministry, by your leaders is important. They may recognize that they can't perfectly deliver on the aspirational goals of the health system yet. That's okay. as long as they truly are striving for the same goals with the same values. So you need to see that alignment. That can be affirming, and that we're all working together to improve an imperfect system. We need to work to make sure that resources to allow us to connect with meaningful work are brought forward as much as possible. So we want to help patients. That's the meaning and purpose for most healthcare professionals. How can health systems be smart about how they allocate resources, no matter how limited or constrained they may be, in support of that meaningful work? Promoting autonomy. This actually is better in many places other than the United States. We are highly regulated in the United States. We drown in paperwork and forms and authorizations and approvals for insurance coverage. There's a great deal of physician work in the United States, which has very little to do with direct patient care. It's different in other countries. You may actually have more autonomy. It may be less of an issue for you, but it's worth at least reflecting on. Recognizing that we are more than just our work roles and honoring those is important. And as I've mentioned, seeking meaning in work. This has been summarized again in that paper from colleagues at Mayo. We need to be able to acknowledge and assess what our issues are, and not just the negative parts, the strengths as well. Where are we doing better? Where do we have things we need to maintain? Leadership matters, community at work matters, values matter. All of these really summarize points that I've already made, and they're here as a reference and a resource in my slide set. This goes into further detail. This is really too detailed to go through point by point. And on some of your computer screens, it'll be too small to even read easily. But it's provided as a reference that's worth reflection potentially, both as individuals and leaders, to help you identify where some of the levers might be to try to improve well-being. So there are many individual factors we can take ownership of individually. There are also work unit, organizational, and national policy level factors. And we'll come back to some of these when we talk about how we've implemented a model like this at Mayo Clinic. But again, this is not meant to tell you a prescription for well-being, because that varies from individual and practice to individual and practice. One size does not fit all. Again, I shared this slide earlier. There are menus of solutions that are very broad and very diverse, and they are worth exploring to see what might be adaptable in your local environments. They're out there. But what I'd like to do is spend the rest of my time giving you an example. And so we published our development of a framework for well-being for all of our employees across all of Mayo Clinic, which is in multiple states across the United States of America. We have 84,000 employees across all of Mayo Clinic at this time. How do we optimize well-being across such a diverse healthcare system? And it goes back to what I mentioned earlier. We start with a framework, and then these specific tactics can be built off of that framework. This QR code, which should hopefully work through the slides as the PDF is shared with you or on the screen, links to an open access article in the journal Mayo Clinic Proceedings from March of this year, where we report in detail on the development and early implementation of this framework. So let me say a little bit more about how we did this. First of all, it was important for us to have our well-being approach reflect what our employees needed, what they told us they needed. So if you try to impose a well-being solution onto others, that's risky because everyone's needs differ, and what resonates with one group may not resonate with another. So we wanted to make sure that we had the voice of our employees incorporated into our model, and we co-created this framework. As we engaged with our employees, with surveys, with listening sessions, we got feedback on some key themes. The first of these was a recognition that our most valuable resource in our healthcare system are the people who deliver that care, our employees. And we sometimes feel like that's arrogant, inappropriate. Our most valuable resource, well, what is it? Is it our history? Is it our culture? Is it our patients? Is it our leaders? But the reality is the people who deliver healthcare and honor the mission of healthcare organizations are the employees. What we resource demonstrates what we value. I'm going to say that again. What we resource demonstrates what we value. If we internalize that our employees are truly our most valuable resource, then we need to invest in them. The second point that our employees shared with us was that privilege in healthcare is a two-way street. What do I mean by that? In many healthcare systems, people bond with their organization, with their hospital, with their colleagues, and they feel it is a privilege and an honor to serve others in that setting. It is also a privilege for those healthcare organizations that skilled, talented, dedicated, committed healthcare professionals choose to apply those skills at that organization, in that city, in that country. And people need to feel that. They need to have that validated. They need to feel valued. The third bullet point then is being cared for and valued is essential. And finally, our employees shared back to us, without sharing my definition with them in advance, that well-being to them meant being supported in achieving their greatest desired potential, which was supportive of my own internal definition of well-being that we were bringing to this work. We then developed a mission statement and a vision statement for our well-being efforts at Mayo Clinic. So our mission is to inspire and cultivate a workplace culture where we care for one another, each individual experiences personal and professional fulfillment, and employee well-being is a foundational priority. It is absolutely essential to meeting the mission of healthcare. Our vision, thinking forward in time, is that Mayo Clinic will model a values-aligned culture where all individuals have the support necessary to do what we do best and thrive in doing so. We provide compassionate and exceptional care for our patients and for each other. And I would say this is not unique to Mayo Clinic. This is across every healthcare professional on the planet. This is what we aspire to do. Importantly, these mission and vision statements have been endorsed by our top level leadership. So even though we are not perfect in meeting these objectives, we are not perfect in every day or in every environment in delivering optimal well-being. Everyone knows that this is what we are striving for together. Our model for well-being is aligned around 5 focus areas that every employee should expect in their work experience. They should expect a healthy work environment, opportunities for personal enrichment, community at work, being valued, and meaningful work. Each of these is explained a bit more on the left side of this slide. I won't read all the words to you, but I will just point out a couple of highlights. Healthy work environment includes things like physical and psychological safety. People working to help others should not do so at risk to themselves. And where we as individuals, or more importantly, as healthcare structures, can protect healthcare workers and keep them safe, they must do so. Community at work is about connection with our peers and our colleagues and our communities, building this sense of belonging in the environments around us. And meaningful work no surprise by this point of your time with me, is about employees finding purpose and fulfillment in their work, aligning with their skills, strengths, and values. Now, each of these 5 focus areas reflects the voice of our 84,000 employees. What works or is most relevant in your healthcare setting might deviate slightly, but I suspect these core principles will resonate in some way for almost everyone. Now, at the center of this visual, there are some fainter words written in a gray font. Individuals, teams, leaders, Mayo Clinic. These illustrate the shared levels of responsibility. So as individuals, we have a role to play in these 5 focus areas. We also have these act at the level of the team and work unit, at higher leadership levels, and at levels of organizational policy setting and advocacy. And so I'm going to give a couple of examples of each of those elements as we get to the last few minutes here. So having this framework leads to a matrix that can be developed where we have the 5 focus areas and we have the 4 levels of action or responsibility, and we can start mapping potential solutions to each of these cells in the matrix. And that's something that we are actively doing across Mayo Clinic. Lots of people have great ideas to promote well-being, but they often are fragmented and disconnected. It's not clear how they fit into the larger network of solutions that people offer. Or are there too many solutions in the, well, we want to remind everyone to exercise and get better sleep. So, there's some individual components, but we're not doing enough in leadership development to help our leaders learn how to embed well-being as a foundational priority in the care environment. Or it might be unbalanced in other ways. But this mapping of the focus areas and the levels of responsibility allows proposed solutions to be placed into this matrix so that you can get a sense of where are we strong, where are we less strong, and where do we have the greatest need. Because as you talk with your people or you think about in your own practices, where am I struggling the most? Well, that's where you want to put your solutions. And by having this menu, it allows people to then select in a more sensible, thoughtful way from that very diverse menu of solutions that I illustrated in that incredibly complex bullet point slide a few slides back. So this is an example. It's a partial list, but I want to speak to a couple of these. First, healthy work environment. As an example, at the very high level, not individuals, teams, or even local leaders, but at the organizational and even government level, has to do with how we protect mental health for healthcare workers. In the United States, our credentialing language in the past required disclosures from healthcare professionals about whether they had a mental health condition or had ever been treated for one in the past. We have ample evidence, multiple published studies to show that when you ask healthcare professionals those kinds of intrusive questions, and they know over their careers they're going to be asked those questions, that during training, they are less likely to seek help when they struggle because they don't want to have to report it later. We also know that having a history of a mental health condition is not relevant to one's ability to safely and effectively take care of patients. What is relevant is if someone has an active health condition of any kind that impairs their ability to safely and effectively take care of patients. That is in the public interest. Those questions are okay because they serve the public interest. Are you able to do your job? Anything beyond that, however, is intrusive, inappropriate, and actually heightens the stigma around mental health care. So a few years ago, Mayo Clinic advocated to our state government to change the language around credentialing for health professionals. And in fact, earlier this year, we passed a law in the state of Minnesota, one of the 50 states in the United States, banning inappropriate language for all healthcare professionals in their credentialing processes to promote help seeking and reduce stigma around mental health concerns. Credentialing can still ask questions about any condition that currently impairs one's ability to safely and effectively take care of patients. That's fair. But questions about histories or diagnoses that are treated and stable are inappropriate and actually are now illegal. This is a model for other states across the United States, and it's an example of institutional advocacy. This can happen in other states. It can happen in other countries, depending on what the baseline regulatory environment is. I'm going to say a bit more about individual approaches to community at work in a moment, because I'm going to share an example of a randomized trial. But we also have modules and training sessions for leaders. So an example here is a course for Mayo Clinic leaders. How do you promote performance by recognizing and empowering your employees? What are effective ways to do that? How do we help our leaders in their career development more effectively amplify well-being behaviors and experiences for people in their teams? So I mentioned the community part of things. We conducted a couple of randomized trials over the last decade. One I'm going to share with you here is called the Colleagues Meeting to Promote and Sustain Satisfaction, or COMPASS Group trial. And this study was it built on a previous study where we showed that facilitated small groups of physicians meeting on a regular basis could increase their meaning from work and reduce key aspects of burnout. We then followed that up with a less stringent design where groups of physicians were able to meet together in a self-formed, less facilitated, less structured setting. They would meet every other week, roughly, for about 1 hour at a time and location of the group's choosing. We did not protect any clinical time for these groups, but we did pay for their meals, up to $20 per person per meal. And then they had up to 12 sessions over a 6-month period. The topics that these groups would discuss were related to their lives in medicine. That was essential. This was not a free-form venting session. It was not talking about the weather or their kids. This was talking about work-related experiences. So, for example, in a category of meaning in work, we would ask people to reflect. Why do you do the work you do? Think about that for yourself. Share it with each other. From a teamwork and social support standpoint, we would ask these groups to brainstorm ways that they might promote collegiality in their hallway or in their work unit. And from a personal strengths and adaptive coping strategies standpoint, an example of a topic was talk about a work-related problem that's been bothering you. Give each other advice about how to handle the situation and come up with a plan of action. And they would work together, sharing their experiences, breaking down boundaries, and recognizing we have so much more in common. And we don't need to be isolated, and we don't need to feel like we're struggling alone. We can actually be each other's source of support. The results of this study were that burnout improved, depression symptoms improved, and people were less likely to report that they wanted to leave the organization over the next 2 years. So this was effective for key aspects of well-being. It was effective from an organizational standpoint in retention. And what this demonstrated was that an institutionally supported, modestly funded, individual commitment requiring curriculum could benefit multiple domains relevant to physician well-being. So this paper has been published. The reference will be on the PDF of the slides. Feel free to email me as well, and I'm happy to share the full manuscript. Now, there are some operational points here beyond the study. When you have dispersed healthcare settings, Can this work in a virtual environment rather than having forced in-person meetings? Well, sharing a meal doesn't work as well when you're virtual. But we have since demonstrated, since this trial, that groups that work virtually using Teams or Zoom or WebEx or whatever venue you want actually can still benefit from that community building aspect of this kind of intervention. And we have groups across Mayo Clinic right now that meet on a regular basis virtually, and they report to us that they are experiencing similar benefits. We do not make these mandatory because the menu for well-being is different from person to person. This is part of the menu that's available for our Mayo staff. We do think it's important that a team be intact over at least a 6-month period so they can build that sense of community in a consistent way. We don't think groups need to be assigned. They can be self-formed, but either way works. We don't think you need a trained facilitator because we've demonstrated that self-facilitated groups work just fine. And then finally, we have just expanded in the last year to include interprofessional, multidisciplinary groups with key benefits. So, for example, we have intensive care unit teams that are working together where you have nurses, physicians, desk staff, respiratory therapists all meeting together, building camaraderie, sharing experiences, and drawing strength from one another. It is also relevant, however, to have profession-specific groups because the experiences of particular job roles do differ from job role to job role. And sometimes having a group of nurses together is really important without having additional noise from the experiences of people in other roles. So variety is essential. Again, the bottom line here, though, is why do these groups work? Why does any well-being intervention work? And I think they work because by sharing these experiences, they help participants connect with meaning, values, and purpose. They share strategies to promote meaning, values, and purpose. They are reminded that they are part of a group of colleagues who share these objectives and values, and that is very uplifting. And no matter whether it's groups like this or an efficiency in how you do your paperwork, if it allows you to focus and reflect more fully on what matters most in medicine, and for most of us, it's reminding us of our connection in healing relationships with patients. Anything that promotes that will promote well-being. That looks different in Rochester, Minnesota than it does in Namibia or Ethiopia or Malawi or the Netherlands or Vietnam. But the underlying principles are universal. My contact information is here. Again, my email, various social media handles where I post weekly on Wednesdays with well-being updates across the literature. I'm going to stop there, and I would welcome comments and any other questions that anyone would like to contribute at this point. I will again thank you all for the incredible work you do on behalf of patients wherever you are. It's an honor to call you a colleague in this wonderful profession across all of planet Earth. And I look forward to being part of an ongoing global learning community as we try to promote well-being, help people thrive and flourish, so that we can bring our best selves to the work that we want to do. And then finally, a thank you to Dr. Zaru for the invitation to speak with all of you and share some of these thoughts and open up this dialogue. Thank you. Oh, you're muted, Tomika.
Okay, I was just saying thank you so much. Thank you so much for all that information. Thank you also for freeing up your time. If there are any questions, we can take questions there. You can post them on the Q&A or raise your hands. From my part, I'm very impressed that there's 84,000 staff that the Mayo Clinic has been able to to bring together, and I've heard that the Mayo Clinic has a very good culture of employee safety and employee well-being. But if I look at where each and every one of us is, I sort of think, well, how do we get there? How do we even begin this process? And for me, from what you said, listening to the voice of the employees might be a very good place to start. But how do you do that if leadership is not involved?
Yeah, absolutely. And I think leadership is essential, and it can be challenging if leadership doesn't want to prioritize these things or doesn't know how to prioritize these things. And so my approach to that, and I've learned this the hard way over the years, if you approach leaders, and many on this call will be leaders in some way themselves, and in your healthcare teams, you're a leader in a local environment. So I don't want to make this an us-them thing either. But if we think about leaders in high-level decision-making positions, if you approach them with, we have a huge problem, you must do X, Y, and Z. If you don't do this, you're a bad leader. We rock them back on their heels and they shut down. That's not a productive approach. And we live in a society, well, I'll speak for the US, and I think this is true in a lot of places, where unfortunately we've sort of devolved into whoever yells loudest gets the most attention. That is not productive. And so in well-being, it's much more helpful to approach leaders with, hey, can we talk about what your goals are for your leadership? Oh, you want to deliver better healthcare for the population. You want to do this in a sustainable manner. You want to have the healthcare workforce stay in our country. I share those goals. And I think I can help you deliver your goals. Can we talk a little bit about that? And now you're approaching it from a common purpose standpoint rather than as a threat. And that doesn't always get you all of the way right away, but it does start a more positive conversation, because now it's about, well, okay, what can we do to meet our shared goals in leadership and for healthcare for our hospital, for our country? And then you can figure out where are the incremental steps that we need to take. We're not going to flip a switch and suddenly we have a perfect healthcare system. Newsflash, there is no perfect healthcare system. We're big at Mayo, but we have our own issues. We have lots of resources, but that does not make us immune from other challenges. So it's about looking at your local needs and saying, what steps can we take? And as a leader, being brought along in a supportive way to think about, hey, taking care of our healthcare workers actually is part of meeting my leadership objectives. That to me is the first approach, is not scaring leaders away, but actually engaging them as partners where you're offering help. You're offering a perspective to say, hey, I know you mean well. I know, give them the benefit of the doubt, even if you don't believe it. I know that you want the best for our population and for our healthcare workers. I have ideas on how we can work together to that goal, because I think that is an honorable goal and it's an important one. You start there, and then you think about within, to your point about listening to your healthcare people. What do they need? What are the critical fundamental issues? And can you lean in to those, even in small ways, to show signs of progress? Don't think that you can, fix everything at once. That's a recipe for getting nothing accomplished. Pick tangible targets that align with what people say they need. Be realistic. In the United States, for example, and maybe this is true in other places too, despite our resources, one of the common things that people will say, well, what do you need for your well-being? I need more money. Well, really? In the United States, I think that is less true than it is in a lot of other parts of the world. And yet we still have people say, well, their first thing is because they can't really think about anything else. Like, well, if you just give me more money, I can make more choices. Um, Healthcare systems have limitations. They have finances they have to balance. And so you may not be able to give everyone a salary increase. But what else on the menu can we do? Well, you know what? Salary is going to be tough. What other benefits can we offer? Are there other things that we can do? Do we partner with public transportation to give people discounts or free transportation vouchers or things that, okay, I'm reducing your expenses. I'm not paying you more, but I'm actually making the money you do have go further because we're partnering with other groups, because we've engaged with our civic leaders to say, hey, a healthy healthcare workforce is essential for the work that we need to do as a healthcare system. So let's partner. So think about those collaborative efforts to try to take small steps that look like progress. And then when you make those steps, highlight them, because those give evidence to your leaders that you're not attacking them. You're looking for wins that help them, and you're a part of that positive process.
Okay, thank you. That was good. Any questions? I also have another question. With the Compass study, you said institutionally supported. So is this something that has to come from the direction of the institution, or is it something that healthcare workers can sort of collaborate and do on their own?
So the reason that we emphasize the role of the institution supporting this is because we think shared responsibility is important.
Mm.
So healthcare professionals, by meeting in these groups, they're giving their time, and we're all busy. So that's an investment. So our argument was, well, the institution needs to model shared responsibility and give something. There are ways to do that that don't cost institutions more money. So, we have the institution paying for these lunches periodically. You could do this as part of a regular staff meeting, for example, where food is already provided. At many organizations around the world, there are periodic regular meetings where food is provided. You could use that and say, hey, we're going to dedicate these meetings to people are going to break up into their small groups. And the food's already provided as part of the meeting, but we're going to prioritize this time for people without an additional expense to the organization. That's our perspective. Certainly, individual groups, if they anticipate value in the structure of meeting together, and they want to go ahead and uh, fund that and support that with their own investment in their own meals. There's no reason they can't do that. And I personally think that the benefit of sharing experiences with colleagues would still hold. But I also want to be mindful that often as individuals, we feel like this is all being put on us to address. And our approach was to try to model, hey, it's not all on you. We're going to do this together. When resources don't allow that, or when individuals want to do something on their own, though, I think they could.
Okay. Thank you. That makes a lot of sense. We still don't have any questions. So my last question from my side is, you've talked about individual responsibilities and systemic changes that need to come from leadership. So my question is, for that one health worker that finds themselves in a situation where they feel burnt out, they don't really see a way out. They're actually thinking of, I don't even know why I got into this profession in the first place. And they are looking for a way out. What would you say to that healthcare worker?
Yeah, so these are so difficult, and unfortunately, every country has their tragic stories and experiences. I know you've had one in Namibia recently that Dr. Zaru shared with me. A couple of things. First of all, every country has to determine what its mental health infrastructure is. So in the United States, for example, we have a national emergency number that is specific to mental health crisis. So for general emergencies, the number from any telephone, any cell phone in the United States is 911. We have a mental health emergency number as well, 988. And that is advertised, that is publicized. And when people are in crisis, we want them as much as possible to have just a flicker of that number flash through their brain to say, maybe I can call that number. We can't make them. And this is the tragic part of it, is when someone's in a moment like this, you're hoping that something that you've put into the water, so to speak, will give them pause. And I want to be careful because I'm not a psychiatrist or a psychologist. So when I talk about serious mental health diagnoses, I'm speaking in generalities, not as a clinician in those domains. But we're trying to create environments where people are familiar with resources to seek help. The second piece is we need to create environments where people don't feel stigmatized, so that if they are struggling or suffering, they are not made to feel like this is a sign of weakness. This is a sign that they are deficient, that they are less than, because these are normal human experiences. Those of us who may not have had mental health crisis over our lifetimes are fortunate, but we are no better and no different than someone who has, any more than someone has an experience with a broken leg or high blood pressure or any other health condition. And we need to be very careful about not stigmatizing mental health challenges because they are common. And this differs from culture to culture, from country to country in the acceptance of this. But this is something that we need to normalize help seeking. We need to destigmatize mental health challenges. And then the final thing that I'll say is we need to work more to build the safety nets among our colleagues so that we are really our own brothers and sisters keepers, so that we know, hey, I'm not feeling good. I have people that I trust that I can reach out to. I don't need to feel alone, because other people, one of the benefits of our compass groups that people have told us is just sharing the experiences. So often we hear, I thought I was the only one who struggled with this. And it doesn't have to be a mental health issue. It can be, I'm inefficient in my paperwork. It takes me too much time. And then hearing two other people say, oh my goodness, it drives me nuts. It's a huge issue for me too. Oh, maybe I'm not actually so terrible. We can all try and problem solve. Oh, I feel a little better, even though I'm still inefficient. I feel better that I'm not performing so poorly as I thought. And so I think building that network of community and shared experience and opening up the willingness and the acceptability of, if I'm working with you, Dr. Zaru, and over a few days, you seem a little more withdrawn, or you're a little more negative than you usually are. I'm not seeing you smile like I'm used to seeing you smile. That it's okay for me to say, hey, Tomika, are you okay? Just that conversation and being willing to lean on each other and ask about each other, demonstrate care for one another, can save lives.
Thank you. That's very meaningful. And I'm pretty sure that it's also very impactful. Thank you so much. I don't see any questions. Any questions from the attendees? If not, I think we can close there.
Yep. I will send you a PDF of my slides, Tomika, just as I did for the first session. So that'll come. It'll probably be later today. I do have a few meetings coming up, but later today I will send that. And again, the group has my contact information, and whether it's the group live today or someone who may watch this on the recording, I view this as a global learning community and an ongoing dialogue. I'm looking forward to learning over time from what works in your environments so that we can learn from those as well.
Thank you for that. And we also look forward to collaborating with you and letting you know how we progress and where we get to. Thank you again for everyone that's made the time to join us this evening. Thank you to Colin for connecting with us, and thank you to technology also for making this possible. We've heard a lot, and we've also realized that we have responsibilities and the places where we work have responsibilities, but there is a place to start. I think that's what I'm getting. It's not all doom and gloom. There are things that we can do, and there are things that we can push or start into motion, which is a good place, which is a good thing to be. So if you have any lingering questions, like Colin said, you can contact him directly, or you can contact us via email or via our social media we have LinkedIn and we have WhatsApp, and our emails are on our website, so you can connect with us at any time. This is going to be the last webinar for 2025. Our next webinar will be hosted in February 2026, and we hope that you will be with us at that time. Thank you so much, everyone. And Colin, thank you again.
Okay.
Good evening.
Thank you, everyone.
Good afternoon for you.
Yes.
Okay. Bye-bye then.